No problem.
The postpone and stop elective surgeries will have a lasting effect on all stakeholders, including patients, health workers, and healthcare organizations. The question is, after COVID-19 pandemic, we will return to normalcy or a new normal. It is my pleasure to present Professor Goha. She will answer, I am sure, my question. She's a professor and consultant anesthesia and pain medicine from Aga Khan University, Karachi, Pakistan. She was a founder of first multidisciplinary pain setup in Pakistan and chaired the Department of Anesthesiology at Aga Khan University for 2 consecutive terms. Currently engaged in various international projects, including World Health Organization pain guidelines. Author of more than 100 peer-reviewed publications and recipient of many national international grants. I would like also welcome to our invite panelists. It is an honor to present Dr. Andrew Norris. He's a chairman of the Department of Anesthesiology of King Faisal Specialty Hospital and Research Center, Riyadh, Saudi Arabia. Dr. Antoni Sabater Pes, he's a professor in the University of Barcelona and chairman of Anesthesiology, Reanimation and Pain Clinic Department from Hospital Universitari de Bellvitge, Barcelona, Spain. Welcome also Dr. Samad Swalin. She is Associate Director of Research Department and Senior Consultant Ophthalmologist of Key Case, Riyadh, Saudi Arabia. Welcome Dr. Abdul Sahur Khan. He's the Chairman Anesthesia Department and Director of High Dependent Unit of Chiefs of the Operating Room of Key Case, Riyadh, Saudi Arabia. And finally, welcome to Dr. Newman Ackman. He's a Senior Consultant of Anesthesia Department. After the lecture, both audience and panelists will have the opportunity to ask questions. Dear audience, you can write in the chat, and panelists, you can raise your hands, please. And I would like to kindly remind that you close your microphones to avoid any interference, please. And before the lecture, Dr. Sahur, he wants to add some comments. Please, Dr. Sahur, go ahead.
Thank you, Dr. Lucia. I think you already introduced Dr. Professor Gohar Afshar. And so I don't want to take any more time. I just welcome her, and I would say thank you, Dr. Gohar Afshar, for your precious time that you've given to us to talk to us today. And again, I want to repeat the same request. Please keep your microphone off so that to avoid any disturbance during the lecture. Thank you very much, and I hand over to Dr. Gohar Afshar to please start the lecture. Thank you very much.
Thank you very much, Zahur, the Lucia, the all academic leaders at the platform of Global Education Forum. And I think this is a wonderful opportunity for me practicing here in Pakistan, the lower middle income countries, and I can share my own experience and what is happening all over the world. I would like to share. Okay. So, can you see my slides?
Yes, Dr. Agohat.
Okay, so the topic which I chose deliberately, because this is a very pertinent topic since we are working in operating room and ICU, and this pressure from different areas to do different elective procedures and all these things, we really managed with very, 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 somehow diplomatic way, and somehow the difficult to convince people that why we are stopping all these elective surgeries. Before I go to the detail, I would just like to say that I don't have any conflict of interest, although because I'm a senior anesthesiologist and I'm a in a working committee that is making a decision, but that is my routine activity, nothing to do with this particular project. But one disclaimer I would like to share, that because every day, a lot of literature is coming and this situation is evolving, the pandemic evolving. So maybe in my presentation, with all my best of my efforts, maybe I miss some of the most recent evidence. So for that, my apology. But even in the morning, I again do the search and find some of the new things, and I added that. So this is my institution. This is the first international university of Pakistan where I worked. And this international university is associated with the quaternary care academic medical center. And the quaternary care means that we are doing from smaller ambulatory cases to the transplant surgeries, and we are doing with very good reputation in this region. And I'm proud that I'm working here. And the two of our alumni, that is Dr. Noman and Dr. Zahoor, who are working with the KKES, we are very proud that they are our alumni. So what I plan in the next 25, 30 minutes, that I would like to just give a very brief background, that in what circumstances we think of interim cancellation of elective surgery. Then I will talk about what is the problem to provide a routine health care in this COVID-19 problem. And then a very interesting Lancet report that came on 29th May, and I could approach this Lancet report on 1st of June, which is Monday. Then after the Lancet report, then we talk about the hot question, and the Lucy asked that normalcy or a new normal, and which is a very, very pertinent, that we have to understand that now we have a new era. This COVID pandemic, where there are so many uncertainties, we cannot be sure about how can we resume the normal life before COVID pandemic. So we'll talk about the safe resumption of elective surgery, when and how, and I will try to give this area with evidence that's available. Some of the very important principles and consideration that every academic medical center, I'm not saying that the small hospitals are not following, but whatever literature is said, the academic medical center, they are trying to set the principles and the consideration, and then they make a institutional guidelines to do these when and how. So when and how is not a cooked thing that we can apply each and everywhere. You have to drive your own pertinent things and then make your own institutional according to your geographical location where you are working, and then you can make a safe resumption. Out of all these things, what is a new thing comes, and which is certainly the initiative of American College of Surgeons, which is a medically necessary time-sensitive prioritization process, MENTS. And this MENTS, they believe that this MENTS actually, because this is the objective criteria, and American College of Surgeons believe that if we imply this medical necessary time-sensitive prioritization process, MENT, with the true spirit, then we can have a good outcome measures in this difficult time. As you know that I'm living here in Pakistan, and we in this area we have been dealing a lot of disasters in the last 2 decades, especially, or 2.5 decades, because of the geographical location, a lot of war problems, the bomb blasts and everything. So we're very used to have a mass casualties and disaster planning. And normally whenever this happens, the bomb blast comes and a lot of mass casualty comes. So one thing which normally we do, we always, do the interim cancellation of, elective surgeries. And that was our norms in the 2.5. Maybe you are living in a very peaceful area, so you don't know that when the mass casualty comes, like we have been facing. So for interim cancellation is our normal processes in place in our institution. Okay, whenever this mass casualty comes from the bomb blast, what we have to do, 1, 2, 3 things. And in the first stop thing, that stop the normal operation for elective surgeries until this disaster planning is settling down. But COVID-19, and we all know that this COVID-19 made this very difficult to deliver the time to routine healthcare, because there's a peculiar thing in mass casualty of bomb blast. Whenever we're dealing the patient, we never a fear of spreading disease from here to there, because we know that these are people comes from the bomb blast or the major road traffic accident or things like that. So we handle them. Of course there's a lot of burden and volume, but this is not that the disease is spreading from here, from patient to the staff worker health. This is additional and peculiar problem with this COVID-19. And we also know that this COVID-19, although majority of the physicians are not affected, and maybe people would mind, but what I believe that the people who are on the frontline healthcare workers, this is their problem. Now, for example, if gastroenterologist or cardiologist, or maybe they are affected because their routine health line is care is not, the patient are suffering and they are approaching the doctors. But dealing the COVID-19 patients, there are some of the specialty who are actually they are on the frontline workers, and anesthesiologist and some of the discipline of surgery like trauma surgeon, all these things, they are the frontline workers with us. So all in this difficult situation, so all the non-essential or elective surgeries and procedure that utilize the personal protection equipment, because in COVID-19 pandemics, if you're doing any case, elective case, then you cannot, even if the patient is not the COVID confirmed, if it comes through the ER, it is we label as a COVID suspect, then you have to use the PPE. And we must not be conducted to preserve the PPE. We all know that if you're providing this PPE, because it will all of a sudden the demand comes in society. Even in our institution, we face in the initial 2 weeks a lot of problem, because this PPE is not available, except that we have a mask, but we don't have other thing, the respirator we don't have, and we don't have the full kit. So these are issues that if you are using, if you are in the area of ICU or operating room, then you have to use them. And another peculiar thing, that if your staff is busy and if they are simultaneously contaminated by the patient, because the PPEs, proper PPE were not available, and we are sending them for quarantine. So and this is what happened to every institution, that initially when we don't have a full PPE except the mask and the gloves, so we face problem. And at one time, I still remember, I'm sharing my experience, that 35 people from our department, including anesthesia residents, some anesthesia faculty, the OR staff, they were quarantined because of this problem. And this is a unique problem of COVID, which is not in the other disasters like mass casualties. So this report, I'm starting before jumping towards that topic, though I'm sharing this Lancet report that comes on 29th of May. And this Lancet report, the title of this Lancet report, the mortality and the pulmonary complication in patients undergoing surgery with perioperative SARS-CoV, that is COVID-19 infection, an international cohort study. So this is an international multi-center study. 235 hospitals were included of 25 countries. And all patients undergo surgery who had COVID-19 infection confirmed within 7 days before surgery or 30 days after surgery. And they, when they were making, what I was reading about this article, very thoughtfully they make this inclusion criteria, then how will catch the possible population that is suffering from the COVID-19. And the primary outcome, they were aiming for 30-day post-operative mortality, and they were assessed in all enrolled patients. The main secondary outcome measures was pulmonary complication, and the pulmonary complication defined as a pneumonia, acute respiratory distress syndrome, or unexpected post-operative ventilation. At the time of analysis, and they did their analysis on May 2nd, they started the study in the mid of the February, and then they start collecting the data. The 30-day follow-up had been only reached in 1,128 patients who had surgery between January 1st and March 31, 2020. Now, in this interesting results I'm only sharing, So out of this, 53% of the patients were men and 523 were women. And 19% were younger than 50 years of the patient in this patient cohort. 31.3% were between 50 to 69, and the highest number, which is 49.5% patient, were more than 70 years of age. Emergency surgery was done in 74% of the patients. So in this cohort, majority of the patients who operated during January to March, they were for emergency surgery, although the 24.8, that is roughly one quarter of the patients, were for elective surgeries. An indication of surgeries mainly the kind of cancer surgeries and unavoidable. So COVID-19 or SARS-CoV-2 infection was diagnosed preoperatively in 26.1% of the patient, with timing of diagnosis missing for 88%. Now, these were how they diagnosed, because this is again a very, very challenging thing of their diagnosis. Now, laboratory testing is still, the swab test is still on the top. So again, in this cohort, 85.9% of the patients were diagnosed with the typical, PCR test. In these patients, however, 7.1% required the CT chest, and some of the patients they diagnosed clinical on the basis of the clinical finding, because the clinical findings were very typical of the cohort, but they constantly, their swabs were coming negative, and their chest was also not typical, the picture of the glass opacity. They did not find that. So 30-day mortality in this Lancet report, they found that 23.8% of the people, they have 30-day mortality. That is, one third of all patients die during this COVID epidemic surgeries. If you split the data, how many elective surgeries patient died and how many emergency, so emergency were 28.4 versus 18.2 elective. So elective mortality is 18.2, again is a high elective mortality, especially if you are not anticipating in ASA 1 and 2 patients. Surgeons are not anticipating their death. 18.2 is a big number. 1/5 patient die. Every 5th patient per surgical patient would die, whereas elective emergency is 28.4%. And they were mainly the older age patients, and higher emergency we found in emergency. So in this light of the Lancet report, certainly everyone from 29th May, if you see, there's a lot of blog is coming, a lot of tweets is coming about the decision that has been made by 4 societies, which I'm going to come in the February month of the February, about the safe resumption, how and which I'm going to share, is now debatable. Now, this is a roadmap that in the month of February, the 4 societies, very pertinent societies that were the work in operating room, they decided to restart, elective surgeries. Now, what are the 4 societies that they make this joint statement and joint guidelines? The American College of Surgeons, American Society of Anesthesiologists, Association of the Perioperative Registered Nurses, American Hospital Associations. And all these 4 sit together. They made a very nice document, and they develop a roadmap to guide the readiness, prioritization, and scheduling. How you will prioritize which surgery you have to do first, and how should we schedule according to the availability, knowing that the COVID pandemic can come again. So they set some basic principles. And they said that every institution, so this guide very clearly in preamble, they write that every institution implement these principles and consideration according to their own requirements. What is happening there? Because we cannot say what is their own situation, what is the situation of the testing facility, what is the situation of the PPE in that particular institution, what is the burden of elective surgical cases. So these principles are generic, and we have to extrapolate things from this document and apply or make a new guidelines for your own institution. So the first is the timing of the reopening. When we start the elective surgery, a lot of debate, if you read the literature, a lot of debate is there when to start. And majority said that if you have, wherever you live in, whatever geographical area you live in, if there is a decline in 1 week, some said 1 week, then you start resuming. But after the lot of consensus and debate, this 1 week is not acceptable. And there's certainly the 2 weeks a universal acceptance that if in the area where you are working, if in that particular geographical area there's a decline, then you have to do. So I will go one by one. So there are the 9 principles with the consideration. The first is timing, second testing facility, then personal equipment, protective equipment availability, case prioritization, post-COVID issues, and 5 surgical phases from pre-operative anesthesia care to the post-operative discharge, then collection and management of data, then the COVID-related safety and the risk mitigation surrounding the second wave, which is again eminent, and everyone has said that this is one should very well plan if you start elective surgeries, and additional some co-related issue which will talk about. So first is the timing. When to start an elective surgery, and this is a principle that they said, these four institutions, that there should be a sustained reduction in the rate of new COVID-19 cases in the relevant geographical area for at least 14 days, because some of the group were in the favor of 1 week and some of the group in the favor of 4 weeks. So there's some in between consensus come, and it is like a 14 days. Then the facility shall have a appropriate number of intensive care beds, non-ICU beds, PPE, ventilators, trained staff. This is very important. And the first principle, if you have all these things, because in geographical area there is a constant decline for the 2 weeks, and all these are available, yes. And what you consider that, if the principle is yes, then what you consider that? Sustained reduction in the rate, as I told earlier, 14 days. You have to be very cognizant that this is important. After thoughtful discussion, this 2 weeks comes. So this is important to consider that until 2 weeks decline trend you don't see, which one should not start the surgery. Then the provision of facilities, that makes sense to everyone, that until unless you have a facility, because in the COVID-19 pandemics, we have additional requirement apart from the other resources, the PPE requirements, additional ventilators requirement, ICU additional beds, because a routine ICU beds, for example, if you have a routine ICU bed of 10 beds, then you cannot use for surgical patient, because we expect that at the same time, the ICU being used for the COVID patients that are coming. So we have additional beds, then you can do elective surgery bed. Otherwise, a priority to provide the available beds to the COVID patient. So you have to see where we are. Then availability of trained and educated staff appropriate to the planned surgical procedure. And this is again important, until unless you have a human resource. And at the same time, as I told you, that the paramedical staff, your faculty, consultant, the ratio of quarantine is not here. I'm referring to in my big city of Karachi, there are 5 leading institutions, the tertiary care center, and some of the center, uh, the whole ICU staff became, COVID positive. And at one time, they face a lot of problem because nobody's there to run their ICU, and they requested the surgical resident or the trauma surgeon to run the ICU, because the whole ICU staff and consultant, they got infected and they quarantine for I think 2 weeks or 3 weeks, and they face a difficult time. So these are the things which we have to consider starting the elective work, knowing in this area, and you can have this kind of a acute shortage. Then another principle, the second principle, is the COVID testing within a facility. Again, the institution should have an independent, they should not be dependent that you are running the hospital, but you send your patient to other institution or lab for facility of this kind of a test. The where the institutions where you are starting the routine surgical, again you have to have this COVID testing, because you have to do the universal testing for any patients who you plan for elective surgery. You have to convince your patient, if the patient is coming for laparoscopic cholecystectomy or total abdominal hysterectomy, you have to convince the patient that the universal testing of this COVID is safe for him for her, the patient hai, then also for a paramedical staff or everything. So without the universal testing, no elective surgery can be planned, and this is very important. So the point I'm trying to make it here. So facilities should have this testing at the same place. You cannot make the person inconvenient, because we are currently facing problem to convince the patient to have this testing. They said, why should we do? We don't have any symptom. Though we try to always, try to convince them that this is for your own good outcome. We also mentioned that the outcome may be different if you, unfortunately, you have asymptomatic COVID positive and we do elective surgeries, and at the end, the outcome is different. So we have to really convince the patient. So in this situation, you have to make the environment friendly, that the patient come to the same hospital and the testing should be there. And so you can, and again, because of this false negative, we have to sometime we have to do not one or two or sometimes three tests. So for the convenience of the patient, this is important. So what we consider that availability, accuracy, and the correct evidence regarding the test, including turnaround time for test result. Now, initially, if you remember, majority of the institutions and whatever literature I'm reading globally, so 48 hours times is required. But nowadays, with all these modification, now we can have a 12 in we can have a result in 12 hours. So unnecessarily patient cannot wait, because again, this is very important. Then once we convince the patient that you have to test for this COVID, then you have to ask the person that once you get the sample, after immediately after that, you have to be quarantined, you have to be isolated, because before surgery, because if giving sample, and after the giving sample you again start moving here and there and exposing, so the test is invalid. So this is a very, very difficult challenge, that convincing patient that you sent a sample for COVID, then you have to quarantine or isolate in the home. You don't go here and there, because you will not be exposed to any other person except what is your routine before you're giving a sample. And this is important consideration for the testing. And again, we also have to know that your institution should have not only the facilities should not cater the patient, but also you should be prepared that anytime your healthcare worker also require this testing. So you have to have enough number of test kit, so you can provide for the patient and also for the healthcare provider. And this is very important. Until unless you don't have a good number of kits at the same facility, don't start any elective surgery. Then certainly the personal protective equipment. Again, this is one of the very important resource. Until you have these personal protective equipment available for handling only the COVID patient, because if you are starting elective surgical patients, no matter how good your infection control strategies are there, there's always a chance that the patient who is COVID negative preoperatively, they may catch the infection in the hospital where the COVID patient is also there. So again, then this same patient might require the post-operative care with all these PPE. So this is again very important to remember. And this is that was a principle, and this important consideration that you have to make actually the calculation, because we really have to make a calculation that if we are doing 39 elective cases, and if we have a 60 patients every day in the ER, and the 60 patient, how many patients going to the ICU, how many patients going requirement discharge their mean length of stay in the hospital. So all these calculations is based on your own local data, because different type of patients are coming in the different institution according to geographical area. So this is important. And the policies, whenever you are making or for your own institution, this is important that the policies for the conservation of PPE should be developed. This is very important. For example, the intubation team. Now, intubation team, until unless you have enough people, a separate intubation team should be there in all such institutions where people are thinking of resuming a normal, elective surgical plans. So this is important. And if you don't have, because this is one of the very important consideration, intubation team, and because of that, a lot of senior anesthesiologists, all over the world, they get not tired, because intubation team means that all the time only the most senior anesthesiologist, who's a consultant or professor or that called the associate professor, that person only can do intubate, not any other junior than that person, to avoid aerosol, spread and all these things. So this is important to consider. Then case prioritization is scheduling. Certainly, again, this is American Society of Surgery made some kind of a prioritization list, saying cancer-related surgery, non-cancer but urgent, something like that. So the facilities should establish, but what we believe that it should not be only by the surgeon decide that this is important surgery. So institutions should make a committee that consists of surgeons and anesthesiologists and also the nursing staff, that and mutually they decide which case should be done as elective and which should not. And every day this exercise is happening, because we are going through the same phases every day. This committee meeting of 1 hour is not easy to make consensus of giving, the priority list. Surgeons ask somebody else, the nurses say this patient required this kind of a support, we cannot provide this certain support, then anesthesiologists have our own issues. So the cases where all these three stakeholders, they said that yes, we can provide a safe delivery of healthcare, that patient only be scheduled in the list. And this is important in this consideration, which I earlier on the slide I mentioned. The surgeons are rely on objective scoring system, which is MENTS, and I will talk about that later on. Okay, so specialty prioritization, always ask the specialty surgeon, and we did ask all specialty. The eye surgeon asked, we asked the eye surgeon, we asked the cardiac surgeon, give your list of priority. What is your priority 1 for elective cases? What is your priority 2 for elective cases? And then we follow accordingly. So this is important. Also, we should be very careful giving the whole space to the elective surgical procedure. No, whatever the number of operating rooms and staff is available, start with only with the 25%, and don't go above 50% until unless you find that the second wave of the COVID is not coming, because you cannot reach to 100% of the normal surgical volume as we were before this COVID-19. This is important. Always strategize that we should avoid Saturday, Sunday, because healthcare workers in this time are becoming fatigued. So we need to give their break. Or also every day we have a news that 1 or 2 people from the OR staff or from anesthesiologists, they need quarantine, because our healthcare provider counter for healthcare, we have actually the university hospital and the institution devise a daily screening for every worker. So if I start working in the morning, or a resident or technician, so they have to follow that application for everyday screening. And if everyday screening they found, and that everyday screening is checked by the family physicians. So if they found anything alarming, they just send an email to that person and to the chair of the department that this person needs urgent need of testing and quarantine for whatever days they advise. So this is important, that we have to take care of their fatigue, and this off and on quarantine, all of a sudden people become infected, and then we have to provide them care. So this is MENTS, which is now surgeons are relying on that. And currently we are using, we means that committee is using objective criteria for prioritization. And this MENTS, which is medically necessary time sensitive prioritization process, has 3 components. One is the procedure component, where we have to see the procedure is small, 30 minutes or 35 minutes or 60 minutes. Then we have to length of stay, we anticipated the length of stay, whether the patient most likely required the post-op ICU bed or not, and these things like that. So this is a scoring system, and we have to give number 7 to 35. So this is the first component of this scoring system. Second component of scoring is the disease. So again, we have to see, because all these patients in telemedicine go through the anesthesia, pre-op assessment, and then we did all these numbering, that the non-operative treatment options, the non-operative options, the impact of 2 weeks delay, and all these things, and we have to together we decide. And then the last is the patient. what type of patient, lung disease or obstructive sleep apnea, COPD, and everything we have to give number. So the nursing is doing this very smartly. This MENTS scoring, and when they will come to the committee, before coming to the committee, every day they just calculated all the requested surgical procedure with all these parameters, which is procedure, disease, and the patient. On the basis of that, there's a kind of a planning that if MENTA score is less than 25, okay to proceed. Okay, and all these individual component may, which is a procedure, patient, patient and disease, you have to give number in each and every component, and then which is overall 21 components in all three areas. So score is 25, okay to proceed, and if score is 105, procedure not justifiable. And a middle line, which is a gray area, here we have to decide back and forth depending on the number of cases booked every day. So but there are issues related with the increased volume, because initially when we started, or any institution started after 3 months lockdown, a 3 months period, then of course we expect that the patient would come. So there's a possibility that there's an increase, sudden increase. You can see that, but again, you have to see with this increased volume how this increased volume will be catered by the other support services like radiology, pathology, because remember that the COVID patients workload is there, and on top of that, this workload is coming for the same staffing with the same equipment, with the same CT scan, MRI, radiology lab, everything. So we have to be very careful that this is, we have to go step by step and very meticulously we have to decide. Now a very important five-phase step is coming, and we all know that when the patient come to the surgical clinic and the surgeons think that this patient now requires surgery, then certainly there are five steps. They send the patient to the pre-anesthesia clinic, and then things are started. So currently we are doing the teleclinics, and I'm sure majority of the places in the world which I have been reading, majority are discouraging the in-person clinic, anesthesia clinic. They are doing the teleclinics. So we are doing the clinic on Zoom, and we talk about the patient. We try to see mouth opening and everything, chest auscultation. We cannot do that. We always explain the patient, and on your admission, because we did we did not do your examination, so some of the things might come after your admission and you might not be operating because of this. So we always declare this thing, but majority of the patient, by the history taking, their gravity of the problem, the medical illnesses, medication is on, somehow we are arranging very well. All these patients, because they are doing on the teleclinic or not in-person clinic, so certainly after the admission we have to do another examination, the quick examination, so immediately preoperative examination. And we all know, although we all familiar because of the JCI requirement that every patient needs a quick uh, uh, preoperative requirement, but not all the institutions globally accept or practicing the JCIA. So maybe some of the institutions are not doing the immediate preoperative before going to the operating theater, but here, yes. So phase 3 is intraoperatively, and we have to be very careful about the need of revision of pre-anesthesia and the pre-surgical timeout components in this patient, because in timeout may now we added elective surgery, may be added COVID positive, COVID test done, yes, COVID positive or negative, except negative, because the positive test we are not doing any surgery. So this in timeout you have to, again, you have to add this thing that the patient is COVID negative or COVID positive in elective surgery. So this is again the guidelines who just as I told you earlier, that nowadays the intubation and extubation, they are the most tricky time, where this aerosol generation can cause infectious environment and can harm the paramedical staffs and other healthcare workers. So this is important, and this is I don't know what other institution is practicing, because I did not find in written what they are doing. But what we are doing in every patient, we are doing rapid sequence induction. We are not doing bagging in any patient. And after the rapid sequence induction, we are using not the blind intubations, and we are using with the camera intubations. So, and the senior most person. And same in emergency situation, but in elective situation, we are very careful that we will not do any regular bagging and masking and all these things. Or certainly the PPE, we are using it in every case. This is important. And then phase 4 is post-operative period. Again, in post-operative period, in many institutions, people are practicing ERAs. So now, because in the COVID pandemics, some of the nursing who are dedicated for this ERAs, now we don't have that kind of activity, because they are now using with the rapid response team and all these things. We did not hire any, or I'm sure nobody hired any nurses because of this crisis, economical crisis also. So somehow we are shifting all these things. So it all depends what type of nurses you are there, and whether you can continue IRAS or not, or whatever type of post-operative plan you have to do. Again, the facilities in the recovery room should be the same as in any situation. However, we have to be very careful that COVID versus non-COVID, recovery should be separated, because in the same main complexes, I don't know, in every institution the system is different, but for example, in our institution, we have a central OR operating theaters, so we have to make it separate to recoveries. And this is again important thing by learning from your own data. So this is important, that your own local data would guide you, improving your own guidelines, improving your patient related activities. For example, in our own setup, we have to change every alternate day some of the thing. Now, for example, initially we said universal testing of any patient who booked for procedure is 48 hours before that. In the 48 hours, when they are waiting for the result to come, they will be quarantined at home. But now, because of some technicalities, the patient in the long lines and all these things, so now we have changed this 48 hours for 72 hours. It's very unfortunate, but because of the limited space where the test is being done, so these kind of modifications you have to do. What are the resources you have? So these are the different consideration according to that. Then and you have to consider that how many, again, own data, how many of patients testing positive but go to the ICU, unanticipated stay, unanticipated admission, all these things. Then COVID related safety. This is important, that the facility should have implement social distancing policy. Each and every staff should know how to keep a distance in your own team. Sometimes there's always a reflex that the nurse in the theater would come and start saying something very close to you, and you have to remember, you have to place a big cardboards that keep the distance. Now this social distancing is important, because apart from everything, all these things, which is like in majority of institutions, and what I'm reading from the literature, that institutions who are making a very good policy, but these things that in the dining hall should not have a sitting facilities. Dining hall should not have a sitting facilities. People take food and then they go their own place. Don't eat together. These kind of a thing, which also we need to consider when this kind of a elective workload you are planning. So this is then additional some of the issues like healthcare workers well-being, and this is very important, that we should have a proper kind of a desk where the healthcare, anyone at any time they can call, they can share their problem, and you have to tackle on priority. Because until now, for example, the Italy cases and all these cases, because the healthcare workers well-being is a very important this area, and you have to plan, the hospital administration should plan how they will keep this healthcare workers well-being. So here, because I think time is over, so here I'm just finishing my giving us some key messages. So when resuming the elective surgery, healthcare providers should monitor their communities. What is the COVID-19 pandemic status? Because you need minimum of 2 weeks time for the downward trend. Okay? Setting protocols for healthcare workers and patient personal protective is very important. And you have to be very careful about all these things. Setting up of a governance committee is very important. That will make a decision every day. real-time decisions. And you may be the policy which you make in the month of March is not valid, is now in the month of June. So the constant, you have to be very open-minded. And if anything comes on your table, then the committee should decide. Not that we have made a policy, then you have to stick. No, if somebody pointed out some of the issue pertinent to that issue with the COVID and you can improve that, yes, it has to change. And then remember, in the future, the routine preoperative screening for COVID might be possible with rapid test. Currently, we are doing in 12 hours and maybe with low cost that have low false positive result. But a hospital acquired infection, remember, because in some of the recommendation, what I find missing one thing is a hospital acquired infection, because this hospital acquired infection is not stopped. This is already, this entity is already there. So this COVID is over and above the hospital acquired infection. So the hospital acquired infection strategies should continue. In fact, this is more robust because now we are dealing another kind of infection, the COVID pandemic. So this you have to keep in your mind. And strategies are urgently required to minimize in-hospital COVID transmission, which is very important, and mitigate the risk of post-operative pulmonary complications in COVID-19 infected patients whose surgeries cannot be delayed. So I hope, and here I'm just finishing my presentation, and I hope that we will in this together be safe. And thank you very much. Thank you very much.
Thank you, Professor Gohar, for this excellent lecture. Let's move to the questions. First, I would like to start with our invite panelist, please. Yes, close your, please, Doctor.
I'm closing, yes.
Yes,
yeah.
Thank you so much.
Yes, please. You were very patient, and I took, I think, 45 minutes. I'm sorry for that, but I think the topic so vast that I tried to finish in time, but I didn't.
No, thank you. Okay, we can start with the questions.
Yes, please.
Please, our panelists. Dr. Andrew, do you want to start, please?
Sure. Well, thank you very much. I think I enjoyed that a lot. I mean, I know there was a lot of information, but it was all very obviously relevant and quite practical, I think, which was good. And in fact, right at the moment, we're in the middle of quite a strong surge here. So we've recently suspended or resuspended actually our kind of planned and urgent work, and we're really only doing very urgent and emergency surgery again. And of course, we keep revising these plans for reintroducing work, and I think those are some excellent guidelines with the MENTS work and so on. It's huge issues, potentials for conflict, I think, with colleagues and things, arguing over case scheduling and so on. So I think to have a tool that's kind of co-owned by the organization is pretty helpful. I'd be interested to know, whether you've been using the MENTS tool or something similar, and if so, what your experience of it was.
Dr. Gohar? Can you hear? Okay.
Thank you. Yes. Okay.
Now,
so yes. So what we did after stopping everything, when we started surgical slot again, so again we sit together with the chair surgery and the 1 or 2 leading surgeons, and then a head nurse and all these things, and we said that because, and this is we're talking about a month ago. We said that no, because in our area somehow COVID is at that time, because not situation is different. So I'm talking about when we started resuming activity. So we thought we started. So first we thought that we just give a slot for discipline wise, not by individual surgeon wise, because we said that whole discipline of surgery department or neurosurgery department or orthopedic department, they themselves decide, we are giving one slot per week. You decide, all 5 surgeons, according to your priority and MENTS. Okay,
Mm,
yeah, these are the important, and give us the booking, the official booking. But sometimes they fail to make a consensus and they start sending individual emails as well. Although we said that all disciplines is the pediatric surgery, 5 surgeon decide, cardiothoracic 5 surgeon decide, general surgery is 22, so they decide themselves. And we give empowerment because the American College of Surgeons said that the discipline should give empowerment. We are giving this time, we are giving to you. We don't have much time because we are starting with only 25% of the time. So this is the maximum time we are giving to you. You prioritize, just tell us, we'll provide all everything, facilities. But sometimes what they have been doing, I know, I understand their stresses and frustration and all these things, and over and above, because we are working in a private institution where money is also an issue, and somehow the salary also based on your volume. So this is one of the area as well,
mm,
because the institution provides the basic academic salary. For example, if I'm a professor, so whether I'll do 1 case or 20 cases or 25 cases, my academic base salary, which is a professor, would continue, but my clinical supplement will vary. So surgeon has a lot of pressure because volume is going down, so they're anticipating the surge. So this is a hard fact that this is a self-sustainable institution. They face this problem as well, and we face this problem as well, because surgeons are not willing to 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 give slots, and we cut down 75%. So we give time. This is your time, 12 hours. You 8 surgeon decide what is your priority, and they said that they decide on MENTS. Okay? In some part, they required our own assistance. For example, the patient is sick, requiring post-op ventilation, their pre-op anesthesia said something, so then certainly our anesthesia is also part of that. But not with a true full spirit, because sometimes we found that MENT says something, but they send a list differently. But because we empower the group that you decide in this slot what you want to do, we'll provide anesthesia cover. So we started with the 25%, and they try to increase the time, but we did not, because again in Pakistan, somehow not the second wave peak hasn't reached, and we are facing a lot of patients in our COVID ward, because we have a separate COVID ward, three floor COVID ward, and we have a lot of COVID patients. So we don't have an extra nurses or doctors and front care workers, so we cannot increase the time. But somehow by default, somehow they are now, last week it increased to 32% from the previous volume. 32%, we aim for 25%.
right.
But it's a very difficult prioritization.
Absolutely. Yeah.
Testing is not an issue. Testing is an issue. Initially, they said that the patient have a stigma, they are not willing. So they
Right.
said no, period. We have to have a universal testing. But what we are flexible now, initially is a 48 hours now, because they said there's a long list, a long line, a patient is not willing to wait for long. So now increased time for 72 hours.
Okay. Okay. Can I have a short supplementary question? So the next question was, once you've given the surgeon, the service, the slot, then I get that they prioritize what goes in it. How do you weight how much time to give to each service?
Actually, if you just see initially when we close everything, so we closed everything: outpatient clinic, surgical outpatient clinic, anesthesia clinic, theaters.
Mm.
Then at the first step, we started the teleclinics, only the teleclinics. So in the teleclinics in Pakistan, although everyone has got smartphone and they're familiar to the using Zoom, but even then some of the patients said no, we have to come and see because we have to examine you. So certainly the volume in initial weeks down to 10% only. The teleclinics only cater 10% of the outpatient volume, and all
Right.
the surgical volumes come from the outpatient. Then the hospital administration convinced us and everyone that start wearing the PPE, start the in-person clinics. So then in second phase, we started at the same time the teleclinic by one surgeon doing using two rooms, one for teleclinic and one for in-person clinic, physical clinic. Patient comes. After the phasal patient coming, then somehow the volume increases. Up till now, what we understand, there is not a long waiting list. The majority of the surgeons, because of the competition in this big city, they say 2 weeks also a long waiting time. But there's not a long waiting time, because why I'm saying the 2 weeks is also long waiting time in Pakistan or in this city, because we have a very big center nearby, a competitor center, and certainly if we are not doing, and some institution is less flexible than ours, then they, and although they are also requiring testing, but there are some of the, for example, they are not using MENTS, so maybe they will be accommodated there. The patient might go there. This is a surgeon's point of view, that we don't want even 2 weeks waiting time, but we don't have more than 2 weeks waiting time. But for surgeon, this is long waiting time. If you ask a surgeon, they said this is long waiting time.
Yeah, sure. Yeah. Okay. Thank you. I better let someone else in.
Thank you very much.
Thank you, Dr. Andrews, for your questions. Dr. Sabate, can you ask your question, please?
Yeah. Good afternoon, everyone.
Yeah, how are you?
I'm the only surgeon among the panelists, so I would just want to congratulate Professor.
I can't hear you.
Can you hear me now? Is that more clear?
Sorry, I can't hear you.
Can you hear me now?
Yes, now I can hear.
Okay. I want to congratulate you, Professor Afshan, for this beautiful illustrated presentation. I'm a surgeon, and I just have a couple of comments and questions.
Again, your voice is lost somewhere.
Okay. Here, you can hear
No,
me?
no, it's better. It's better.
Okay, good.
Yeah.
There are some surgeons, especially in the United States, who wrote a letters requesting to add the risk of COVID to the surgical and anesthesia informed consent form. So, uh, are you doing that in your current practice? Do you advise the really the healthcare workers to implement this for the future, especially where many of us are starting to do the elective procedures? That's number one question. And the other one is that you address very carefully the false rate, positive and negative of the PCR test, which is the gold standard, and the availability, the cost, and everything. And my question is that what about doing it to the healthcare workers, especially the anesthetists and surgeons who are doing surgeries every 2 weeks? Is that part of the guidelines? Did anybody address that or not? Or are you doing shifts in the anesthesia and surgeons in every 2 weeks? Some team will be on, other team will be off. That's one of the concern that we have as surgeons. The third one is that I noticed in your presentation you mentioned that some of the recommendation is that to start with outpatient cases followed by inpatients. Could you elaborate on that more?
Actually, your MENTS scoring system, the last question first, the MENT scoring system says that if the duration is less, the 30 minutes and all these things, so start a resumption of these kind of a procedure. For example, if the kid is suffering from the tonsillectomy, this is like MENTC said that, not we. But unfortunately, if you ask me our own experience, we are hardly handling the ambulatory cases. We are mainly the inpatients, and the reason of asking they're asking about the small procedure, because they said that because inpatients are required for COVID, problems and COVID unexpected number of volume. That's why they said start with this patient, but that's not the case. now you ask about the testing, which is a very, very sensitive issue. So currently, we are not doing in every patient, in every healthcare workers for COVID testing. No, we are relying on a daily screening where few questions we ask in the morning. Every employee when come, either I come, I start.
Hello? Hello?
Hello?
Hello?
Yeah.
One moment. Dr. Gajon? Dr. Gajon?
I think she got disconnected. I saw the name appear there.
She disconnected?
Maybe just later. Yeah, I think she got disconnected. Just maybe give us a few seconds. Maybe she
Yes,
joined
yes.
again.
Yeah.
I think it might have been the laptop battery.
Yeah, this is happened, no? With the live situation, yeah.
Yeah.
Don't worry. I suppose.
I have one question to Dr. Norris, if you don't mind, while waiting for Doctora to log in. Since you're practicing in King Faisal, could you please just update us on the guidelines that you're following in Saudi Arabia in King Faisal Specialist Hospital?
Which,
Point, yeah.
which particular guidelines did you have in mind? Are you thinking about scheduling or?
Yes, the for the scheduling, yeah. Which phase you are now in King Faisal?
Well, the phase we're in right now is that we've got a very strong surge. So, and our own patients are reasonably under control, but we're taking a large number of patients now. We're expecting to take a significant number of patients anyway from Ministry of Health hospitals across the city. So, you know, we've got quite busy intensive care units in the other hospitals. So we'll be taking some of their patients into our intensive care units, and we've expanded our intensive care facility, and we have adopted.
Can you hear me? Sorry, can you hear me?
Oh, we can hear you now.
Yes.
Yeah.
I'm so sorry. I don't know what happened. So where I was talking, I don't know.
Yeah. Don't worry. Well, I was just answering a question of one of our participants whilst you were off, and the question was what we were doing locally in Riyadh and King Faisal in terms of managing our COVID patients and the surgery. I think that was the question. So
Yes, you are talking.
in terms of our
now,
surgery,
okay.
yeah, we're really only right now we're really doing emergency and very urgent cases.
Okay.
And
Okay.
we're
So let me explain.
No.
Let me explain. So we have two routes. First of all, I will talk about the patient, and then I'll talk about the healthcare workers. So when the patient comes, if the patient comes, now we have two types of emergency. One is the non-COVID problem patient comes, and one is the COVID diagnosed patient. So any non-COVID patient comes for abdominal pain or trauma or fracture or eye infection, whatever. So the patient immediately we have sent a sample for COVID, and until the results come, the person assumed the COVID suspect patient, and if the patient remain in the isolation, whatever the reasons, the laparotomy is a cesarean section, whatever. So we label this is a COVID suspect patient, and they will be in isolation. Okay, so they will not come to the non-COVID area. First thing, if the patient results come as a negative, then they will come the non-COVID area. In the healthcare workers, and so for elective surgery, when the patient we see in the clinic and the surgeons plan for a surgery, then they have to, if they plan surgery on Tuesday, for example, and so we expect the 48 hours before the person send the sample initially in our own policy, but because of some technicalities or the lack of COVID testing kit, we increases to 72 hours. But we very clearly said to the patient, after your test, you will be quarantined at home. And this is a very important message, because if patient universal testing is must, if the patient for elective surgery after the test, after the swab, nasal swab, if the person again exposed to the different environment, different people, then this test is invalid. So this is a very important, and normally this compliance of this quarantine after having this test in our own population is not 100%. Patient after giving sample, they start traveling to the nearby city or home or friends or shopping, and then we postpone the surgery. Now comes to the healthcare workers. We are not doing in all healthcare workers for testing, but we are doing screening. But in our same city of Karachi, there are institutions where healthcare workers are required to do testing every 1 month. And I have a lot of objection on that policy. And I personally talk to them. That's why I'm saying to you. Because what I believe, what I understand about this testing, I am not an infectious disease doctor, but what I see the limitation of this testing or the false negative, there is no guarantee that if I, as a healthcare worker, I am negative today, I might not negative. I might be positive tomorrow, and that is a problem with this test. So, weekly or 2 weekly testing is not the solution to me for a healthcare worker. So, for the healthcare workers, we are not doing testing; we are doing screening. That is, every day we have a small application. IT department made a small application of 5 or 6 questions, and in that question you have to answer that what is your today's temperature, do you feel did you have a breakfast, do you feel nausea and vomiting, do you have something, 4 or 5 questions, huh? And on the basis of that, healthcare family medicine read all these daily software application answers and then advise accordingly. One thing, this is like a screening, not the testing. But if somebody is exposed, unfortunately is exposed to the person who later on came positive, then this person will require immediate testing and quarantine for 2 weeks. So we are also evolving policies every day, knowing the limitation of the resources and all these things. So we don't have a very clear answer, but the answer is that we are doing screening, not the testing for healthcare workers routine. But if symptoms are there, or if the person is exposed to the patient, then we do.
Yeah.
Thank you. Dr. Andrews, do you want to finish that you tell before another question? Dr. Andrews, you can continue.
Okay, sure. I can just very briefly. Uh, I mean, I was interested in the MENTS scoring system. We've been doing something similar, but probably with a bit less objectivity. But we've been having a panel, and we've been trying to do that. And interestingly, we also evolved a similar situation where each service, had a nominated representative to collate the required cases and then present them to scheduling. And that, I think that helped. I think that was kind of the main question. I think was how we were running it. I mean, it sounds really very similar. We have a small COVID OR and we have a separate building for COVID positive patients. Although now I think we'll probably spill into designated areas of the the main complex as well, and we'll kind of do a rolling retreat from that. We've also had recently, we've had a significant number of positive staff members. I mean, we haven't had that for quite a long time, but that has crept up now. And so that's obviously causing us problems to provide a service for elective surgery anyway, because many of the staff are off. And it's also hampering our ability to deploy anesthesia staff to help with critical care. So, I mean, I think these problems are being replicated worldwide. I mean, obviously we're slightly different stages. But
Yeah, exactly. Our own issue is somehow, for example, we have a very clear policy that nurses or doctors, they will not move their clinical area. Now, for example, if the nurse is posted in C1 ward, The previous time, some time for socializing, for their own break, they can go to the B1 ward for their friend or something. But now strictly we say no. But in spite of the policy, we often found that the nursing, we found social, not the social very get together, but they sit together. Although we have stopped the sitting arrangement in all kind of dining hall, there's not a single seat. But even then, they found some place and they sit together. And the healthcare, from infection from person to person, is a problem, and we are facing every day. We are sending an email, flyer email, attractive email with a good message, not a very taunting. It's a good message that why we are saying the social distancing is important. But even the healthcare workers are not following these practices, and this is our major issue. Even SOPs, the standard operating procedure in some cases, because certainly we have a combined lounge of surgeon and anesthesiologist, and we try to make a SOP for that lounge as well. Because if I believe that I'm clean, I'm wrong, because I may be the silent carrier. So nobody should believe that I am clean. Everybody should believe that I may have this. If everybody would believe that I may have this, then start precaution not to give infection, not to take infection. So wearing mask even in the surgeon's lounge, these kind of things. Sometimes it really bothered us, because some people are very religiously following, because you're sitting in a one lounge, 20 people together, social distancing, the mask and all the thing, because we all live in a high suspicious area. So these are the issues, challenges, everyday problems. Some people are very particular following, some people are not. Now, regarding MENTS, I think the MENTS should the scoring should what we are doing. We ask a head nurse, which is a neutral head nurse, to give number. Head nurse to give number. We have to educate them that how you give number. So she has on computer. She has a anesthesia preoperative form, teleclinic form, that the anesthesia gave ASA 3. She has a hypertension or OSA, and the anesthesiologist wrote the notes that the patient might need post-op bed. So from where they can get, but they are not expert in getting these numbers. So this is the problem, giving numbers from these record, that is the preoperative record from that. And the surgeon part, the surgeon has to give, because the nurses cannot give the low risk and the patient, if you don't do surgery, then what happened to the expert can decide. So this is, we have given to the discipline wise, the group, we have just give it time, whatever they give in that time, the priority, that the 5 cases in 12 hours, we do that. We do never challenge for why you are putting this, why you are not putting that, because we believe that they are the expert to decide, but we are limiting time for them. No individual surgeon slot is there. It's a discipline slot. That is the major change we did. Initially, the individual surgeons has a slot weekly in the weekly rota. Now the discipline has a slot in the weekly rota, and discipline decide that how to tackle these problems.
Thank you, Dr. Andrew. Let's move Dr. Sabaté for your questions, please.
Yeah. Hi. First of all, I want to introduce to Dr. Colomina, that will be the new head of the department, the new chairman. So also she has been involved on all the things we have done in these days. Maybe she started to have some questions, and I will finish with one question.
Only one question for the professor.
Yeah, please.
Related to for the test, specifically for the patient. Do you consider to repeat the test after the surgery, for example, when the patient if the control before the surgery is negative, is necessary to repeat and confirm?
Yes.
2-3 days after surgery, for example?
Yes. So there are again 2 or 3 type of patients population. If the preoperatively somebody is negative, we'll make sure that before discharge we have to give another test, COVID test. And we have seen that some of the patients who came positive for emergency, not elective, we will find that before the 2 or 3 days they became negative. So that is an emergency situation, because currently we are not doing any elective case for positive COVID. So all the negative COVID when come undergo surgery. So if they are ambulatory surgery, for example, the patient discharged on the same day, then normally we are not asking to repeat the test. But any patients who is inpatient post-operatively, and 24 hour, more than 24 hours or 24 hours, we ask for a repeat test. So currently we are doing in a second post-operative day, that is, if patient 48 hours before universal testing, we elective case we did COVID test is negative, then they go ahead for surgery, and then 48 hours we repeat that. And majority of the patient, for example, hemicolectomy, all these things, patient normally discharge on the fourth day or fifth day. So normally before discharge, we also do one test more. But if the patient is discharged on third day, then normally second post-operative day, we take the last, last record for them.
Okay. Thank you.
Any suggestion? Any experience about this? Dear, do you have any suggestion? Because what we have been reading, and whatever we consensus like policies we are making, if you have any suggestion, you are most welcome to give us.
Also, alguna sugerencia al respecto.
I think it's necessary to confirm this
Maybe 14 days.
And it's necessary to comprove after the patient was discharged from the hospital.
Okay, 10 day. Yeah, this is like in the outpatient clinic.
Mm-hmm.
Yeah.
Yes, that is. Yes, that's the 10th day that we have a policy. 10th day post-operatively is in outpatient, yes.
Yeah,
but before discharge, yes, that's the 10th day, yes.
Yeah, it's better to do after 7 days, better even 10 days. But
yes,
first of all, Dr. Howard, this is a really nice roadmap, but I have some questions in relation with ENTs, because it is nice at the beginning to start with outpatient surgery, because that makes confidence to the people and the workers easy to do. But after some days that all the machinery in operating room is working on, it's quite difficult to maintain this kind of selection, because most of the patients that waiting for surgery in our hospital are major surgeries. So I mean, patients with high degrees in the number of NTS. I mean, patients with bleeding risk, patients with medical conditions, and of course, patients with worse outcome if the patient is waiting for surgery. So I think for non-COVID patients, this classification or prioritization is not so useful. But for COVID patients, this prioritization is very useful, because we know from this paper from the Lancet that the mortality is very high in these patients. And so it is better to use this prioritization for COVID patients, but I think it's not so clear or so useful for non-COVID patients. What do you think about?
Actually, this Lancet paper, at least I read 3 times, because some of the methodological part, like how they enroll, because this is from January to March, and this 4 societies recommendation joint paper comes in the February 28, 29 something, 26 February. So this trial started before this joint statement of 4 societies. So I believe that institutions have a mixed cohort. Some before this joint statement, and some after this paper, because this is very famous all of a sudden in MENT among surgeons. So it was not mentioned in the Lancet paper that the number of patients who enroll in their study were not weighed by this MENTS. So because they analyze on May 2nd, okay, May 2nd, if one of the cohort would come, that in that case the implementation from the MENTS, what I believe, because MEN after the MENTS, it was very clearly written in the, I think it was published in British Journal, that now the elective surgery should follow this score, objective score. It's a kind of a standard they give. That this is kind of a standard that people follow, but it is not mentioned here. I think what you are saying that some COVID patient would require also surgery. So only see the COVID patient requires surgery two category. One is the COVID patient requiring surgery because of the fractured neck femur, emergency surgery, laparotomy. That I think we all agree that we have to go ahead, and we are doing that. Second is that the COVID patient comes universal testing, for example, stapedectomy. Now, if the patient is for stapedectomy and the COVID test comes positive, do you think that we should proceed? I don't think so. We should proceed for stapedectomy. This is I'm taking about the because real cases, because these are happening every day. That people of the for this stapedectomy or uh, the cervical, which is a very bad cervical pain, and a little kind of a fingertip numbness comes, and that patient comes positive. So this patient, we explain to the patient because this neurological deficit was not there and we could have waited. So and knowing the literature, if the COVID positive today is positive, so most likely the negative would come in a couple of 2 to 3 weeks time. So we have to decide which surgeries we can wait for 2 weeks or 3 weeks, because if the COVID negative patients would give a good outcome or mortality is increased with the COVID positivity, and if we can avoid any surgeries, in my belief, I'm not a surgeon, certainly of course the surgeon will decide at the end because he knows the best. I think in some of the surgery like stapedectomy, we can wait for that. Even patients sometimes, I don't know in our culture, when we tell the patient who comes for total abdominal hysterectomy for menorrhagia and hemoglobin drops down to 6 milligram and all these things, but we said that the COVID positive would come, so oh my god, thank god that I know my COVID positive, I will not go for any surgery and I will come for the hospital for 2 months time. So this is like a for everybody, this is a new thing. We are every day we are changing our own policies, and this is like an evolving area. So again, I'm asking you if you have any suggestion. I believe uh, COVID positive patients should not undergo elective surgery, and we can easily wait for 2 to 3 majority. But surgeons knows better now. For example, patient who have adjuvant. For example, we have a lot of patients who treated adjuvant therapy for CA breast, and they got adjuvant therapy, and now they're waiting for the surgery. And these kind of patients, they are really worried that we had chemotherapy, now we after the chemotherapy we undergo for surgery, now because of this COVID positive, what should we do? So we normally believe on a surgeon, how his experience, he tackles, he knows how urgency, although it's an elective surgery, but how urgency in this cancer surgery.
Thank you very much.
Okay, thank you, Dr. Sate, Dr. Colomina. Dr. Sahur, can you ask some questions, please?
Yeah, thank you very much. I think the discussion went very long because it is very interesting. And but my question is about the recommendation of elective testing for. Do you really think that we should test all the patients who are coming for semi-urgent or elective cases? And even we know that, but I mean, it's something. It's a question uh, that is very difficult for many people to to either to justify. So, what do you recommend? Every
uh,
patient should be tested.
Zahur, I think I have a lot of debates, and I actually at the end I somehow convinced my surgical group that I think this don't compromise on this thing, because this is the first good step that will ensure the healthcare worker safety and the patient safety. So there is no, I think this is must step. This is what I feel, that every elective case should have this COVID testing. Although I know there's some false negative, even then 70% who will come positive, at least they will not contaminate the hospital, they will not contaminate the healthcare workers, and similarly their outcome is better than otherwise non-covid status. So I strongly believe the elective cases, even for urgent cases, the only difference, in urgent cases we will not wait for the result to come. We send the sample and we take the patient in a COVID suspect OR. Now we have a 3 COVID suspect OR operating room. We have a separate negative pressure COVID operating rooms, 3. And the remaining 25 is a normal ORs. So even with all these things, emergency, elective, COVID positive, we have an option to provide a healthcare in the COVID suspect operating room. So we are not denying any healthcare, but I think safety of your healthcare workers is as important as the patient outcome. Because if one patient, if you just see one patient coming to the hospital, one day I made a calculation, because whenever we were making policy, one patient who come, for example, hemicolectomy, he will easily expose to minimum of 28 persons, 28 healthcare workers in their duration of stay in the hospital. Shifting of the nurses 8 hours, every day 3 nurses, then the housekeeping staff cleaning their bed, then the doctor with, although the medical students we are not allowing to do rounds, we are only allowing the consultant and 1 resident, the minimum here. Even then, straight 28% would be exposed to that person. So in my opinion, this is a very important, that the person who's coming for elective surgery or semi-elective, the status of their COVID we must know.
Thank you.
Thank you, Dr. Sahur. Dr. Newman Ahmad,
Yeah.
can you proceed?
Thank you, Dr. Gaur, for sharing knowledge with us. It was a very comprehensive presentation and we had a good discussion. So my question is about the pediatric, similar to Dr. Zahur, about the children, what guidelines we should follow or recommended about the children screening, because they come with a history of coughing, and in the children the incidence is much lower. So what we should,
We are following, Dr. Naman, we are following the same. Now, for example, I'm just giving a yesterday example. Every day when the list comes in the morning, because we're trying to we're trying to accommodate discipline-wise listing everything. So some of the patient when come in the operating room list, the COVID status is pending, and every day this is happening. Out of 39, 40 patients, 4 or 5 COVID status is pending. So we expect that by the time tomorrow when the surgery his or her surgical turns comes, then we know that. Yesterday, the 2 kids, a 1-year-old, I don't know from where, because the mother is negative, the father is negative, the 1-year-old bacha come for the cleft palate. And at the time of printing the OR list, it was pending. In the morning when we come and we chase the result, it was positive. We try to do to dig the mother, the father, everyone, both, and they both are negative, but we don't know from where the 1-year-old from where they got this. Similarly, 11-year-old, we have actually data of pediatrics, because again the pediatric surgeon raised these issues. Okay, whether we need the pediatrics needs testing or not. So we have a fair number. I don't right now. I don't have in this computer, but if you are interested out of it, I can provide you. Every day we are getting positive COVID in pediatric population.
it
1
means,
year, 1.5 years, 11 years, 6 years, 7 years. I can. This I'm just giving you the day when I am actively involved in operating room. But every day this is happening. So I can, if you find that I can find my head nurse to provide me, and I will
Do
give
you
it to you.
recommend to do PCR tests for the children who have history of coughing, or they are coming from another city?
Dr. Noman, actually, to be very honest, I am not a,
Yeah,
you're talking about elective. I'm not an expert
yeah,
in infectious
elective.
disease.
Yeah,
We have a
elective.
hotline. We have a hotline. So
Yeah.
normally whenever such patient comes, we just call a hotline. We have a two hotline, one for infectious disease, one for family physicians. So if we have this kind of a consult, we take on online. So we tell that this is a 3 years old child, this is a coughing, and whatever the infectious disease doctor say, we follow that, because we
Oh,
are not expert in that. But for elective surgery, we decided
yeah.
that even for bacha, for any kid, the testing is must.
Oh, thank you. Thank you, Dr.
Yeah,
Gohar.
thank you very much. Thank you very much.
Thank you. Do you have more any questions? And also, assistants, participants, do you have any question you can write? And if not, I would like to have some questions, but because we don't have more time. My first question is to resume the elective surgeries. What should be the total numbers of COVID-19 patients in the hospital to resume the elective surgeries?
Actually, this is not a magic number, any recommendation, any guidelines gave. They said what is, like, for example, your own healthcare setup in your institution. For example, if you in your city, if you did not announce your hospital as a COVID hospital, then we will assume that no COVID patient is coming to you, and whatever the eye surgery, whatever, I'm just giving example. So if the institution or hospital academic center is announced as a COVID hospital, then certainly the COVID hospital have a limitation for elective surgery. Now I'm giving our own example. Now, for example, we have a 900 bedded hospital, and just example, and in 900 bedded hospital, we reserved 200 beds for a COVID patient. Okay, so remaining 700 we cannot offer for elective surgery, because two reasons. Because one, any elective surgery can become complicated and can come to the other area of the COVID, and then even the non-COVID area you may have this COVID patient. And secondly, any time, because in majority of, for example, in our country, we're still waiting for a peak. But the countries where the peak has achieved, the second wave would come anytime. So if the second wave would come anytime, so you cannot resume that 700 minus 200, so 700 beds are for elective normal surgeries. No. The recommendation is that you have to increase in terms of percentage 25 to 50. More than 50 is still not recommended. And certainly we will evolve, the world evolve about these, and we learn every day. So maybe some, but currently 50% normalcy, that's the no normal. You initially said that. So 50% volume we can achieve. We cannot aim for 100%, because this load is unpredictable. Currently, maybe this load is only 20% of the total load, but it may increase at any time.
Thank you. This is true. We don't have magic number. Another question is regarding preoperative assessment. The guidelines said that you need to do 30 days before the surgery. What is the policies in your hospital about the preoperative assessment?
Preoperative assessment, we have actually the surgical clinics or anesthesia clinics are very adjacent. So normally we are dealing two types of, an anesthesia clinic, we are dealing two types of flow of the patient. One is appointment patient, because there are some surgeons who always plan the patient ahead of the time. That is a good 1 week or 10 days. So they always ask the patient to take appointment of anesthesia clinic and then come accordingly. But there are surgeons who see the patient and wanted to do within 2 to 3 days. They said the patient that In anesthesia clinic, there's a waiting, patient line. You go there, wait there, and the anesthesiologist will see the same day. They wanted the patient to be seen in anesthesia clinic on the same day, the day when they decided for surgical procedure, and when they can take a consent from this patient that you are going for a surgery, and that's why anesthesia is required. So we are doing appointment anesthesia clinic, and we are doing walk-in anesthesia clinic. In the walk-in anesthesia clinic, normally we see in person, because surgeons are normally, majority of the surgeons are doing in-person clinic. We anesthesiologists, we prefer the teleclinics. So our walk-in clinic is the in-person physical clinic where the patient comes physically, but the same time one consultant with the 4 resident is doing clinic. So the same time the teleclinic is for appointment clinic. So patient take appointment, and the Zoom clinic is happening every day, and we prefer the teleclinic.
Okay, thank you. Dr. Newman, do you have one question? Go ahead.
It's fine. No, it's okay. It's okay, sir. Thank you. Thank you.
Okay. My last question is regarding to the decision fatigue of surgeons and anesthesiologists. What do you recommend to avoid? Because this is very
sorry, what avoid?
About the decision fatigue of the surgeons and anesthesiologists. How we can avoid
this? The fatigue, the routine fatigue.
Yes.
Actually, surgeons said they have a lot of time. So they said the fatigue is not an issue because the volume has been cut down to 75-80%. So they are relaxed. They are doing cycling, and they are doing, they are on most of the time they're Netflix, and they're watching movies. They are relaxed because their elective work is down. Even some of the orthopedic surgeons who are supposed to be trauma surgeons, they also said that their working hours less, because generally the people in the city, because of the less social activity, the people normally most of the time at home, so road traffic accident and all these things somehow is going down. So surgeons are not fatigued. No, but in anesthesia we have again the 2 or 3 type of anesthesiologists. One is who are doing COVID wards. Now, the COVID ward is a 135 bed ward where is a very, very heavy turnover. And the resident and anesthesiologists who are working there, they are fatigued. And for them, normally we ask to do 1 week, and then we give 1 week off, so they don't come. But one of the group is providing services in operating room. Okay? So they are doing like 2 or 3 days, and again we are giving in between the non-clinical daytime. But one team is for intubation team. They are actually looking after intubation in the whole hospital. Anywhere if the intubation required, they will be called. This team is also becoming fatigued, and we don't have an answer because expertise to do with the scope is not everyone has got. Anesthesiologist has got that. So we are trying to make every day rota for operating room. We are not making a weekly or monthly rota as we were doing before. Only the ICU people we know, weekly we send a consultant for ICU, and that consultant, when we relieve from Monday, they provide service from Monday to Sunday, and then the Monday again a new consultant comes. So they have a break. They have a break. Apart from the COVID ICU, we're also running a normal regular ICU. So the normal regular ICU is also busy, because in the normal regular ICU also catering the medical patients, because the other ward is busy. So the other things are very, very complex.
Okay, thank you.
Thank you very much. Thank you.
I think
there
are, yes,
sorry,
you can.
Yeah, just maybe I think the speaker is also now tired of speaking, but just a short question. Hello, can you hear me, Dr. Gohar?
Yes, I'm hearing. Yes,
Okay.
yes, please.
Yeah, okay. This intubation team, don't you think this is the new, like something I'm hearing? I'm aware of like the intubation should be done by the most experienced person and these kind of things, but an intubation separate team, what advantage do you see to have a team? And do that team, they use the PPE for every separate intubation, or do the same team also come to intubate inside the operating room?
Actually, we wanted, actually, Zahur, we wanted that the person who went for COVID intubation should not come to the routine area because of the infection, all these things. Although the doffing and donning is, there's a very cumbersome process. Now, currently, this intubation consult, which is done by the consultant, is elective intubation. It's not a rush call. Normally, they give a time, the rapid response team give time, rapid response team round every 2 to 3 hours, and they said that there are 2 or 3 potential patients, they might need intubation. Okay? They send a request and they send a pager. Then the consultant send a requirement, कि ये propofol and whatever the medication, all these things. And then one anesthesia technician and one consultant with all the PPE go to the COVID ward and do this intubation. Okay, and normally intubation we take hardly 3 minutes, maybe 4 minutes, not more than that. But this all these things like donning, doffing, and they're coming back to normal, that is actually cumbersome. So I'm not saying that this team is not doing is not participating anything, but we are anticipating that this person would not be easily available because the donning, doffing, intubation notes, handing over to the patient, it easily take 1 hour, and this fatigue and environment of the COVID makes the person is really fatigued. Roughly, for example, last night I was on call, and the COVID intubation was handled by one of my assistant professor. I was handling emergency OR, and he was on COVID intubation. And since I saw him walking 3 or 4 times, going for the COVID intubation, coming back fatigued, tired, and at the end we found that the patient also died. So these, kind of a overall environment. If you go to the COVID ward, everyone is wearing the whole, it is a very to me is a very strange environment throughout. I don't know what the patient would feel. At some time we have to do survey what the patient would feel, that everyone is covered from head to toe. You can't identify who is he. The whole white, long dresses. So I mean, I don't know the need. In fact, my faculty meeting, we also raised this issue that our year 5 our instructors are very competent, and we have to think that for how long we have to keep our senior consultant on floor for intubation. But currently, because of the overall people fear, environment, still we are doing that. We are taking responsibility, the consultant. But maybe in future, because this would not continue for long, for 3.5 months, constantly three consultant on floor to tackle the ICU problems, intubation, and the OR is difficult. Is a difficult task.
Thank you. If there are no more questions, I think for avoid our fatigue also, I would like to say thanks, Professor Gohar, for sharing your experience with us. Thank you, our invite panelists, for your important contribution in this lecture, and thanks to all participants for sharing your time with us. I hope you have enjoyed and the topic has been of the interest of all of you. Finally, from key case, we would like to transmit that life goes on, but to reach safety for our patients and for our health workers, and to provide high quality surgical patient care, we will have to follow together surgeons and anesthesiologists same directions to facilitate life after Corona in our hospital around the world. Thank you, all of you, and inshallah, we can see in our lecture 10 of June. Thank you, Professor Gohar. Thank you.